Okay, for this lecture we're going to be talking about drugs which affect the endocrine system, specifically Chapter 32, Anti-Diabetic Drugs. The objectives for today is first discuss the normal function of the pancreas because it's hard to understand how these medications affect the body if you don't understand the normal function. Contrast the age of onset, signs and symptoms, treatment, incidence, and etiology of type 1 and type 2 because they are a little bit different. And then taking that one step forward and differentiating gestational diabetes from type 1 and type 2. Discuss the various factors influencing blood level, glucose level in non-diabetic individuals and in patients with diabetes. For example, stress can sometimes increase blood sugar in patients who are not diabetic, so that would be one example. Identify the various drugs used to treat type 1 and type 2. And we, of course, discuss the mechanism of action and so on and so forth of those drugs. One of the main, or how you're going to see this lecture goes, we're going to divide this into insulin and then oral agents. Within the insulin, we'll compare the rapid, short, intermediate, and long-acting insulins. And then with the oral agents, we're going to kind of talk about the different indications for them, when they're appropriate to use, and what side effects are associated with each oral agent. I'm just going to warn you right now that you'll probably want to grab a little bit of a snack because this could turn into a lengthy lecture just because this is a kind of a complex subject. Just understand that it could take a little while. You might have to read through your notes a couple times to really understand this. And I'm just going to tell you right now, if something seems weird or confusing, don't hesitate to shoot me an email so I can help you with that. With that in mind, grab your popcorn, grab your pop and your notes, and we'll whip this out. So I'm just going to give you a 10-cent review of the pathophysiology of diabetes. This is a topic in of itself that could take literally 4 hours, but we're not going to do that because nobody wants to sit here for 4 hours in the summer for a pharm lecture. So just a quick overview. They are different from each other. Type 1 is defined as a lack of insulin produced by the pancreas. And this is going to be caused by an autoimmune disorder, and it's typically diagnosed when people are quite young. What happens is the pancreas will function normally for a time being, and then something triggers the immune system to attack the pancreas. And that trigger is typically a virus that will trigger the immune system, and from that point forward, the immune system will look at the pancreas as a foreign organ, essentially. And in those patients, then the immune system will just destroy the pancreas. Unfortunately, type 1 diabetes typically is not discovered until it's quite late into the disease process, which makes it very difficult to prevent and impossible to reverse. By the time it's diagnosed, I think there's only like 5% of a functioning pancreas left. So the clinical manifestations that typically cause this disease to be discovered, there's the 3 Ps plus a few more. The 3 Ps are polyuria, polydipsia, and polyphagia. In these patients, when your pancreas loses the ability to secrete insulin, what happens when you eat a carbohydrate, instead of that carbo being used for energy, it just floats around the system. Now, if your cells do not have a carbohydrate or glucose for energy, they need to turn towards other sources of fuel. And the source of fuel it turns towards is protein. So it starts to eat like muscle, tissue, stuff of that nature. When that happens, it triggers something in your brain that causes you to think you're hungry. So you eat more because your cells are saying, I need glucose, I need energy. And the logical thought is, I'll eat more to get more energy. So these patients eat a lot, but because the glucose is never absorbed, it's never utilized, I should say, these patients eat a lot and they don't gain any weight. Oftentimes they're very, very thin, particularly at diagnosis. In addition, the breakdown protein also triggers them to drink a lot of fluid, and then they go to the bathroom a lot, which would be the polyuria. They'll typically also have weight loss, inability to concentrate, and a couple other clinical manifestations, but the 3 Ps and the weight loss are your biggest ones. So type 1, there's not a lot you can do about it. It's an autoimmune disease. Much like lupus or celiac disease, it's just something the patient has and they have to work into their life to deal with. Now, type 2 is a little bit different. Although we're still talking about inappropriate glucose or insulin secretion by the pancreas, type 2 is a multifactorial disease, which means it's not as cut and dry as you have an autoimmune disease, this is what you have to do. Type 2, you can do a couple things to prevent, and once you're diagnosed with type 2 diabetes, there's some stuff you can do to reverse the disease. So the first thing to talk about as far as triggering this disease are your lifestyle modifications. It's well known that obesity is the #1 cause of type 2 diabetes. And the type of obesity that is most dangerous is going to be fat around your organs, or visceral obesity. When you look at people, or when you look at fat distributions, they'll call people either an apple or a pear, with a pear being you carry your weight more around your hips, so you're kind of wide at the base and narrow at the shoulders, or as an apple, which is what I happen to be, where you carry your weight more in your trunk, and then you have a thin, more thin limbs. If you're classified as an apple, that's going to increase, and I don't say that to be mean by no means, but if you're classified more as an apple, that type of fat tends to be more dangerous in creating diabetes. The next lifestyle modification, and of course with fat, for the most part, unless it's a glandular disorder, you can work out to lose the weight. So that's why we throw it under lifestyle modifications. The next one is going to be diet, and this is going to be a diet which is high in saturated fats, which is going to be your animal type fats, meat type fats, I should say, and low in fiber. So encourage them to flip that around to where they have a diet low in saturated fat and high in fiber will also reduce the risk or can reverse the disease of type 2 diabetes. There is a genetic component to this. If you have a family member, a first-degree family member, so a sibling, a parent, that's diagnosed with type 2 diabetes, we do know you are at an increased risk of developing the disease as well. And then there's also an ethnic predisposition. And if you think of people who have dark skin, so Native Americans, Asian descent, Pacific Islanders, people of that type of ethnic origin tend to have an increased risk of developing type 2 diabetes just because of their genetic makeup. Then the next, number 3, there's going to be metabolic syndrome. Metabolic syndrome is actually kind of a catchphrase for being diagnosed of 3 of the 5 things listed. If you get diagnosed, so the 5 things that qualify here is an elevated glucose level, so you have a high resting blood sugar, high blood pressure, high cholesterol, low HDL, and HDL is your good cholesterol, so if you have a low level of your good cholesterol and a high level of your bad cholesterol, that's bad news, and abdominal obesity. So if you had, say you had hypertension, high levels of triglycerides, and low levels of HDL, just having those 3 qualifies you for metabolic syndrome. And if you're qualified for metabolic syndrome, then that also increases the risk of developing diabetes. And the last one, there's going to be the age. The older you get, just the body wears out and the pancreas doesn't work quite as well as it used to. So type 2 is definitely an acquired disease. It's an acquired disease in which the pancreas usually continues to produce endogenous insulin, but not enough to sufficiently control the needs of the body. So the pancreas is still working. And that's the key difference between type 1 and type 2. Type 1, the pancreas is shot and not working anymore. Type 2, the pancreas still has the potential to work. It's just not working well enough to meet the needs of that individual. Now, sometimes we can modify this by helping the pancreas out with medications or decreasing the glucose needs by a diet, exercise, stuff of that nature. A couple breaking this down just a little bit further under the acquired disease. The first one, there's insulin resistance occurs. And with insulin resistance, insulin receptors become unresponsive or insufficient in number, or both. So they still exist, but they're just not as sensitive to insulin anymore. So when you eat a carb, and your pancreas secretes insulin, goes into the bloodstream, and the receptors are not picking it up anymore. So that's your insulin resistance. Therefore, body tissues do not respond to the action of insulin. And this is why, so people have varying degrees of insulin resistance, and this is why some patients will end up taking 30 units of insulin, whereas others only need 5. The higher your insulin resistance, the more insulin you need in order to produce an effect. And when cells neglect to take in the insulin, it leads to a condition known as hyperglycemia. That hyperglycemia is the core problem as to why all the complications of diabetes exists. And as the body notes the high blood sugar, the pancreas will work to produce more insulin, which then leads us to our second point there, a decrease in the pancreas's ability to produce insulin. And it's decreased because the beta cells in the pancreas is where insulin comes from, and when those beta cells get fatigued from overworking, the compensatory mechanism fails them, and then the pancreas just essentially wears out, gives up, and the patient's in a chronic hyperglycemic state. And again, that's when we start having complications from diabetes. If that's not enough, there's also an inappropriate glucose production by the liver with type 2 diabetes. So your liver's job is to release glucose as needed to prevent hypoglycemia in healthy people. So if you don't have diabetes and you haven't ate for a while because you're working a busy shift or whatever, as your blood sugar falls because you don't have an exogenous source of a carbohydrate, your blood sugar falls, your liver senses that, it lets go of some stored glucose. By letting go of some stored glucose, it brings your level back up and you can continue to function. In people with type 2 diabetes, that mechanism is also broke. So then they become more prone to hypoglycemic issues and hyperglycemic issues, and they're just all over the place. So they have a couple of strengths against them in that aspect. And the reason why we go into a little bit more detail with type 2 is not only is it more complicated, but it's also way more common. There's not an area of nursing that you're going to work that you're not going to work with people who are diagnosed with type 2 diabetes. It used to be just a disease of the elderly, well, not elderly, but at least middle-aged and up. And now we're seeing type 2 diabetes being diagnosed in children because there's such our society's in kind of a swing that our children are overweight and not moving as much, and that's kind of your recipe for developing type 2 diabetes. There's a joke that diabetes runs in your family because no one runs in your family. And that's true. You know, there is a genetic issue, but then there's also definitely a lifestyle modification. And as a nurse or a healthcare worker of any sort, it's important to educate people that they know that what they're putting into their body does harm them. By not exercising, that also harms them. To really educate people so they can help prevent this disease. Because although this disease probably isn't preventable in 100% of people, it's preventable in most people. So that's always our cures to promote health. And we'll go way more into detail on that when you hit like your med-surg type courses. But for right now, I think that's all you need to know about type 1 versus type 2. Just a few more types, or one more type of diabetes would be gestational diabetes. And this would be where diabetes develops during pregnancy. And it occurs in about 2 to 10% of pregnancies. For the most part, once the pregnancy ends via birth, the diabetes will also reverse. So once they're done being pregnant, their body will revert back to their natural state and they won't require treatment from that point forward. But if somebody's diagnosed with gestational diabetes, they do need to be aware that this increases the risk of developing type 2 diabetes down the line. So while the body may reverse itself and go back to its normal being, that's a good cue for people that, hey, you could be pre-diabetic. You might want to take extra steps to make sure that you're keeping your body healthy, because we know since you develop gestational diabetes, you're at a higher risk of developing type 2 diabetes. And then on your outline, skip D just for 2 seconds here and go down to E, the diagnostic testing, and then we'll talk about complications on the next slide. So with diagnostic testing, for the most part, this is done via lab levels. Until blood sugars get scary high, they really don't clinically feel anything. So people can walk around with a high blood sugar and be doing damage to their vessels and not know it until there's a major episode that happens. So the best way to diagnose diabetes is to come in for routine diagnostic testing. Based on your risk factors and whatnot, it might be yearly, it might be every 5 years. There's different guidelines that we don't need to worry about today. Also, as we go through this, I'm just going to remind you that sometimes the normal numbers will change a little bit depending on what resource you use. So these are just kind of rule of thumb numbers. They're not hardcore, and they certainly can change with time. The first lab that we'll use to diagnose diabetes, though, is what we call a hemoglobin A1C or an HbA1c. And what this does is it determines the percentage of a hemoglobin, so a little molecule in your blood, the percentage of that that's been converted, that's been touched with sugar, essentially. We want to be less than, I think the new guideline says 7%, but I saw in the book it was 6%. We want it less than 6 or 7. Now, this is a nice test because it assesses the long-term glycemic control, which is your blood sugar control. What this does is it assesses your blood sugar control over a period of about 3 months, because that's about the length of a hemoglobin's lifespan. So this is a good way to know if this is just an acute incidence or if you've been having chronic high blood sugar too. Then the next one is a fasting blood glucose. The normal is between 70 to 100, and for it to be a fasting blood glucose, people cannot have ate or drank for a full 8 hours. So we tend to tell people come in right away in the morning before you eat breakfast to have this tested. Then the next one's going to be a random glucose, and this is just taken without regards to meals, and we want it to be less than 125. To be diagnosed with diabetes, you get any one of these tests must come back positive, and then that same test is used for confirmation at a later date. So if they do a fasting blood glucose and you're high once, they make you come back a little while later, like a couple weeks later, and retest it to make sure it wasn't just something fluky. And then if you come back positive twice, you have issues. So that's how we diagnose diabetes. As far as why we care about developing this disease is because the side effects or the symptoms, complications of it are quite severe. And I've got this broken into acute versus chronic. Your acute are what going to bring, like the diabetic ketoacidosis, is typically the 3 Ps plus the weight loss that brings type 1 diabetic patients to the hospital. And what happens with DKA is your body no longer has insulin. It turns towards other sources aside from carbohydrates to find fuel or find energy sources. As proteins broke down, it becomes very acidic. So the protein gets broke down, your cell uses some of it for energy to sustain life, but then the rest of it gets released into the bloodstream, and it makes your bloodstream very acidic. And then you end up with what we call metabolic acidosis, and that becomes a life-threatening disease. So these patients who come in with DKA will oftentimes have blood sugars in the 6, 7, 800s. We start them on insulin drips. We give lots of IV fluids. We might be giving potassium, but it's a medical emergency. The next acute complication would be the hyperosmolar non-ketotic syndrome, and this is typically more indicative of a type 2 diabetic patient. Same thing, there's not enough insulin for the body to utilize the glucose for fuel. So in addition to using glucose, it's going to turn towards protein, break down some protein, use that for fuel, and then cause the bloodstream to become more acidic. However, because type 2 diabetics typically still produce at least a small amount of insulin, it's typically enough to prevent a hyperosmolar non-ketotic syndrome from going to a diabetic ketoacidosis. These patients will still come in with sky-high blood sugars and they still get put on an insulin drip. It's just their labs look a little bit different. And again, we'll get into the nitty-gritty of that when you go through like a med-surg course or get into more of your clinical type courses for your respective programs. So those are the acute complications. Now, the other thing with diabetes is there are a ton of chronic complications, and I've just got them broke down into 4 different subsections, although we certainly could elaborate if we wanted to. The first one is arteriosclerotic plaque formation, particularly in the coronary, cerebral, and peripheral vessels. What happens with these plaque formations is if they break off and start moving around, you can have an embolism, or they can actually get so big that they occlude blood flow. When you have occluded blood flow, that's when you have the heart attack, stroke, pulmonary embolism, coronary artery disease. Also contributes to hypertension. It leads to a whole host of terrible things. So diabetes increases your plaque formation buildup. That increased blood sugar also damages, we have it in your book, it kind of outlines the difference between macro versus microvascular complications. Your little vessels that get damaged would be your microvascular complications, so like your retinopathy damages the blood vessels to the eye, which results in blindness. neuropathy. What that does, or neuropathy is another way to say it, is it destroys kind of the nerves and it starts peripheral and works their way in. So a lot of times diabetic patients will have numb feet or numb hands, and they're always numb. They have no sensation left there. And this is why diabetic patients can end up with an ulcer on their foot and have no idea anything is wrong. I had a coworker who once took care of a patient that was admitted for, I don't remember, like a gallbladder or an appendix or something of that nature, but got admitted to the surgical floor because he's going to go have surgery. And she was doing her head to toe assessment, took his shoes off, and she knew he was a diabetic, but she took his shoes off and she's like, "How long have you had that nail in the bottom of your foot?" Well, he was a construction worker, and a couple weeks ago he had stepped on a nail, but he didn't realize it. So he'd been walking around with this nail in his foot and had no idea because he couldn't feel it. And that, unfortunately, is pretty characteristic of diabetic patients, especially if the diabetes is severe. Obviously, that's not the first clinical manifestation, but if they have a severe case of diabetes, that's not abnormal. And he said, "Oh, well, that would explain why my foot kept clinking, but didn't think to take a peek down there." So get ready, you'll see weird things like that. And then nephropathy would just be kidney damage. And that's the next organ that typically goes with diabetes, is the kidney function declines steadily, and then these patients end up on dialysis to compensate or to treat that complication. Okay, so enough about the pathophys and the complications. We're going to talk now specifically about the medications related to diabetes, with the first one being insulin. Now, insulin is required for type 2 diabetics, or type 1 diabetics, but it may only be used as an adjunct therapy with type 2. The reason being, with type 1, remember, those patients do not have a functioning pancreas anymore, so they need some sort of exogenous insulin, external insulin in their body in order to function. Type 2, if their pancreas is still producing some insulin, they might be able to get by with lifestyle modifications and an oral agent, but as type 2 progress, it's not unusual to also have to put them on like a supplemental insulin to help their pancreas along. Regardless if it's type 1 or type 2, insulin acts as insulin is insulin. What it is it's a substitute for endogenous insulin, and it acts very similar to the type of insulin that your pancreas produces. It's kind of the key that allows glucose to go from within the bloodstream into the cells. So without insulin, your blood glucose molecules, which should be used for energy, just float around the bloodstream and never ever pulls it to a cell. Think of it as staying on the highway and never getting into a parking space. It just keeps driving around. Well, as you keep adding more cars, which in this case is glucose, to the interstate, it becomes more congested and you have a higher level. And that's what happens without insulin, without those parking spaces. You just end up with an overcrowding of cars or blood sugar on your highway, and you have issues. Once it gets inside the cell, though, it acts as an energy source, and this is the primary energy source for your body. Your brain needs constant carbohydrates in order to function. If you know somebody who goes on an Atkins diet, which is a high protein, low carb diet, you'll notice they're always tired, and the reason why they're always tired is because they're not getting the carbohydrates their body needs. So although carbohydrates get a bad rap, they're not necessarily a bad thing to have on board. Keep in mind that insulin does not reverse the receptor sensitivity. So for type 2 diabetics where they have the decreased insulin sensitivity, administering insulin isn't going to decrease that at all, which is why you'll eventually have to have a higher dose of insulin as the life continues. Types of insulin are altered to be either short, intermediate, rapid, or long acting, and we'll go through each type here in just a second. And these must be administered by a subcutaneous injection. We can't give oral insulin because the stomach acid will destroy it before it ever gets absorbed. So these patients, particularly your type 1, have to take an insulin shot before every meal. Because that becomes quite to be a pain in the butt, a lot of times type 1 diabetic patients will have a pump, an insulin pump, that delivers the insulin for them. They can just program how many units they want, because insulin's measured in units, and then it just delivers it without them having to give themselves a shot. Type 2 will also need a shot. Depending on how severe the disease is, it might just be before meals, it might be once in the evening, once in the morning. It kind of depends for those patients. Your indication, again, type 1, they require insulin to sustain life. Without insulin, they will die. Type 2, diabetic patients will get insulin once other treatments do not work. And then oddly enough, if a patient comes to the hospital with a really high level of potassium, we can give them a few units of IV insulin to bring down their potassium level. Potassium is a lab that you're going to learn a lot about when we go through our cardiac section. If the potassium level gets too high or too low, it causes conduction abnormalities. So a high potassium, we start worrying about cardiac dysrhythmias and it becomes a problem. So if they come in with a high potassium, we'll give them a few units of insulin, brings it right down, and it's easily treated that way. And then you got to figure out why it was high. So some of the contraindications to insulin. Fortunately, because of the way they make insulin, there's very, very few people who are allergic to it. I honestly don't know what a type 1 diabetic patient would do if they were allergic to insulin, because we don't have a good alternative to insulin as a medication. So that's good. There's very, very few people who are actually allergic to it. The next contraindication would be hypoglycemia, because if you give insulin when the blood sugar is low, it's going to make that condition worse. And then the next one would be hypokalemia. If we can use insulin to bring down a potassium level, it should make sense if that potassium level is already too low. Giving insulin will just decrease the potassium level further. And again, that results in cardiac dysrhythmias. So that's no good. Some of the side effects of insulin, the number one that you need to know is hypoglycemia. If you're taking insulin, sooner or later you're probably going to have a hypoglycemic episode, which we'll talk about how to treat at the very end of this lecture. Some of the adverse or clinical manifestations of hypoglycemia include lethargy, confusion, tachycardia, and if it's not corrected, it can result in coma and death. And people do die from a low blood sugar. Not frequently, fortunately, because it's easy to treat, but people do pass away from it. The next one is weight gain, and that's due to the body being able to metabolize the glucose appropriately again, so then they'll start trying to replace what it's torn apart, typically muscles, other tissues, and these patients, especially type 1 diabetic patients, when they go on insulin, will gain some weight, and a little weight in that case is okay. Now for type 2 diabetic patients, we want to encourage them to exercise and eat right so they don't gain any more weight. So this is another spot where type 1 versus type 2 become a little bit different. The next term, lipodystrophy, is simply referring to, and it's a rearrangement of the fat around the injection site. Because you're giving yourself constant injections, if you use the same site over and over and over, it'll cause it almost looks like scar tissue to build up. So this is why we tell diabetic patients to rotate sites when they give injections. As long as they're rotating the sites, the third side effect, lipodystrophy, won't happen. Some of the interactions, we've already talked about beta-adrenergic blockers and insulin, or not insulin specifically, but diabetic patients. And the interaction with your beta blockers is, one, it masks the symptoms of hypoglycemia because it's very sympathetic in nature. But then it also inhibits the release of glucose from the liver when the blood sugar does drop too low. So it's a 1-2 approach. It's not that they won't be used, it's just that you'll use them with caution, and we'll have to educate those patients to check their blood sugar frequently because they might not feel some of those early symptoms of hypoglycemia. And if you're taking insulin, it just makes it that much worse. The next medication you're going to learn about later this week, and that's corticosteroids. Your corticosteroids are kind of known as the stress hormone in the body. So when you undergo stress, it naturally causes your blood sugar to increase. For that reason, if they're taking an exogenous corticosteroid and they're diabetic, it's going to result in hyperglycemia. Normally what happens if we know they need to take a corticosteroid for whatever reason, inflammation, asthma, you name it, we'll just increase their insulin dose as well to compensate for that. And then the last one's alcohol. Is actually an agonist to insulin and can result in hypoglycemia. So we encourage patients who are diabetic, not that they can't drink at all, but to drink in moderation and to be very smart about when they drink and what they drink. Couple precautions in special populations. Women and children are always special. Children in most of the time you would like to think children are diagnosed with type 1 diabetes, not type 2, but in today's age you'll probably, if you work as a pediatric nurse, need to be familiar with both disease conditions. Regardless of the type of diabetes, if you're giving insulin, it's going to be calculated on the client's weight or the patient's weight. A typical dose is 0.5 to 1 units of insulin per kilogram per day. And you want to make sure you have your calculations right, because children with their low body surface area are going to be incredibly susceptible to hypoglycemic reaction. So it's important to check and double check those calculations. Also, there are certain types of insulin which are not approved for children, and we typically don't use combination. We'll talk about combo products in just a few minutes. We typically don't use those in children because they tend not to handle it very well. The next thing is pregnancy. With gestational diabetes, these ladies do need typically some sort of treatment. If gestational diabetes is left untreated, it can have some pretty significant effects for the mother in the fact that it can damage blood vessels just in the 9 months they're pregnant, but then also it has some pretty heavy consequences for the child as well. Children who are born to mothers who had gestational diabetes that are untreated, the mother is untreated, will typically have a large birth weight, and they'll normally go through a hypoglycemic reaction upon birth. So we want to make sure that we're taking care of women who develop gestational diabetes and stressing the importance not only for their health but also for their child's health, that they're taking the disease seriously and doing what they can to correct it. Fortunately, insulin is a pregnancy category A, so they can use insulin and it's not going to hurt them or their child. Okay, so getting into the different types of insulin, remember I said there's rapid, short, intermediate, and long. We'll just start with the rapid and then work our way down. With the rapid-acting insulin, there's insulin lisopro, which is known as Humalog by trade name, and then there's insulin aspart, which is known as Novolog by their trade name. This type of insulin is going to be the most similar to the endogenous insulin that's produced in response to a meal by your pancreas. So if you want to think of it that way, rapid acting is the most pure, most similar to what your body would naturally produce. Pharmacokinetics, this has got a quick onset of action of about 15 minutes. For that reason, we like to give this injection about 5 to 10 minutes before the patient starts eating. That allows it to be absorbed and starting to work as the patient starts ingesting those carbohydrates, so the insulin can meet up with the absorbed carbohydrate and escort it right to its cell to be used as energy. If a patient eats without taking their insulin, it'll result in hyperglycemia as the carbohydrate floats around the system without anything to let it into the cells. On the flip side, if a patient takes their insulin but then decides not to eat, that insulin's going to grab any blood glucose that's floating around and push it into a cell, and then you're going to end up with hypoglycemia. So this becomes really important to know when your patient's going to eat and to give it at an appropriate time, because too late or too early doesn't work so well. And this has a short duration of action, about 3 to 5 hours. With this medication, you do kind of want to be monitoring your patient for signs and symptoms of hypoglycemia. And a good rule of thumb is to start looking at the peak. So like rapid-acting insulin peaks about an hour after administration. So about an hour after you give it is when you're going to start noting signs and symptoms of hypoglycemia. And the rapid-acting insulin is going to be the most likely to cause the hypoglycemia because it tends to be the most potent, if you want to think of it that way. It really causes a spike. It's good at causing spikes. It's not a very consistent type of medication. The next type of insulin that we have is a short-acting insulin. And this is going to be called regular insulin or Humulin R or Novolin R. And for the trade name, it's always going to have the R at the end of it. So that's one way to connect it to being a regular insulin. If you just if you're in practice and you just see the Humulin R or Novolin R is the other one. The R always means regular and the regular is always a short-acting insulin. So that just might be an easy way to identify that it's regular, and then you just have to remember regular is your short-acting insulin. A couple special things about your regular insulin is it's the only type of insulin which can be administered via IV. So therefore, when your patient comes in with a diabetic ketoacidosis and you have to start an IV drip, this will be the type of insulin you'll give. There's no other form of insulin which can be given IV. So this is something you'll kind of want to start, because if you were to give a rapid-acting insulin IV, it would have dire consequences for the patient. So you want to make sure that you're giving it the appropriate route. And again, this is the only type of insulin which is going to work IV. If you're giving it subcutaneous, so IV it starts to work within minutes, but if you're giving it subcutaneous, we give it about 30 minutes prior to eating, because the onset of action is about 30 to 60 minutes. And again, if you administer this and the patient decides not to eat, it will result in a hypoglycemia. So you really want to encourage the patient, once you take your insulin, you need to be thinking about your food. And even if you're not hungry for a full meal, you still need to eat something just so that you don't bottom your blood sugar out. As far as duration of action, this is a slightly longer duration of action of 6 to 10 hours. Intermediate acting insulin is not used as frequently anymore. Typically, the only time people will use the NPH or the intermediate acting insulin is when they're mixing it with either a short or a regular acting insulin. This one, when you look at it, it always looks cloudy. And when you go through your fundamentals class, you'll get a long lecture on how you mix insulin. But NPH will always be cloudy and the rest of them will always be clear. So that's one easy way to identify if it's an intermediate NPH type insulin. And again, it's typically mixed with a short-acting or regular insulin to help enhance the effects. And by mixing these two types of insulins together, it provides a bolus prior to eating, so your short-acting will be the bolus, and then it provides a basal level, which would be your NPH. So the NPH stays in the system for longer after eating to help prevent a spike after the regular has worn off. When they're mixed, so when you have the short-acting on board, as long as the NPH, there's a higher risk of hypoglycemia than when NPH is used alone. You'll see that the longer acting the medication is, the less likely it is to cause hypoglycemia, although it certainly still has that potential. It just tends to be a little bit more controlled medication, so it doesn't cause as much of a low spike in blood sugar. For intermediate acting, onset of action is about 1 to 2 hours, and then the duration of action is about 8 to 10 hours. And normally if they're mixing, they'll take this twice a day, once right before they eat breakfast, and then again before they eat supper. So like at 7 a.m. and 4 p.m. if they eat breakfast at 8 and dinner at 5. The last type of insulin we have to discuss is going to be the long-acting insulin. And the types here, it's insulin gargulin or Lantus, and then insulin detamir or Levemir. And these are easy to identify because both of the brand names both start with L. So if you can remember L for long-acting insulin, you should do okay in your practice. As far as exams go, I'm always going to have both the brand name and the generic name there. So whichever name you learn by will be fine. They'll both appear on the test, so don't get too hung up on that. This is just a friendly way when you're out working. You might be able to easily identify it. It's a trick I use. If it helps you, great. If not, no worries. Onset of action for this is a lot more gradual. Because it's more gradual, it's less likely to cause a hypoglycemia because it really doesn't have that potent punch to bring blood sugars down. It's also called a basal insulin because it's just kind of like that basal rate or that continual coverage. It's more prolonged and provides a much more consistent glucose control. And it's not unusual for patients to take their short or rapid-acting insulin before they eat and then take the long-acting insulin either once a day or twice a day just to help control their blood sugar. Duration of action is where these differ just a little bit. Levemir does have a duration of action for a full 24 hours. For that reason, Levemir is only taken once a day, and it's typically taken in the evening. Every once in a while, you'll see a patient that swears they take it in the morning for whatever reason, but rule of thumb, most of the time they take their Levemir at night, and it's just a once-a-day medication. Now, Lantus, on the other hand, has a shorter duration of action. It's 10 to 24 hours, depending on the patient. Because it's a little bit shorter, sometimes it'll be administered twice daily. A rule of thumb is the more progressed the diabetes is, the more insulin they're on, and the higher likelihood that they'll be taking their Lantus once in the morning and once at night. If their diabetes is even moderately controlled, they should be able to get away with just taking Lantus once in the evening. But if it's a poorly controlled or severe case of the disease, then they might need it twice daily. If it's administered once, it'll be taken in the evening. If it's a twice daily thing, it'll be morning and night, and you do the best you can to keep it 12 hours apart for control. Now in your outline, and I don't have it on the PowerPoint, but in your outline, there's just a table that kind of lays out the differences of the different types of insulin just to help you disseminate this information, kind of understand how it's similar and how it's different. Our next topic is going to be the fixed combination insulin, and this is going to be a combined NPH, which is your intermediate acting insulin, and then a rapid acting or short acting insulin. And what this does, again, it provides the bolus control with your rapid or short acting, and then the basal control with the intermediate acting. And these, it'll be a name and then a number with a slash and another number. Those two numbers should always add up to 100 because it's measuring percent. So like Novolin, 70-30, 70% is NPH and 30% is short acting. Same thing with Humulin. The first number is always the intermediate insulin, with the second number being either the short or the rapid acting insulin. This combination also very closely mimics the body endogenous secretion of insulin and works quite well for patients to control their blood sugar. The alternate to this would be to actually draw up the NPH and then mix it with the short and then give themselves an injection. So they check their blood sugar and decide they need 10 units of 10 units of NPH and 3 units of regular. So then they draw up their 3 units of regular, 3 units of NPH, mix, 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 inject. That would be if they were drawing it up. These combinations, they'll come in just one, it looks like a pen, like a fountain pen. That's already pre-mixed, pre-worked. All they have to do is attach a needle on the end, dial in the dose of insulin they want, and then give it to themselves. So it's a little bit easier for them to use, and again, it's a good way to provide both a bolus control and a basal control. And then while we're talking about basal versus bolus versus everything else, we will talk about sliding scale insulin. Now, this is a method, and it's quite popular in the hospital settings and for patients to use at home, but this is where essentially the patient will check their blood sugar, and then based on that number that they get, will determine how many units of insulin they use. And the type of insulin we're talking about now is going to be the rapid acting, or in some cases the short acting, but most of the time it's the rapid acting insulin that they take right before they eat and then right before bed. One of the benefits to this is it accounts for variability in natural glucose levels, so it's not just every meal you take 5 units no matter what. It allows the patient to kind of tailor, because your pancreas doesn't just release a set amount of insulin every time you put a Dorito in your mouth. It kind of senses when it's working appropriately. It senses how much insulin it needs to secrete and then secretes appropriately. So this is just one way to help mimic that. The alternate to this would be to do carb counting, which gets super confusing and we're not going to talk about today. But it's just a little bit easier way of carb counting. And how it works, so like say you check your blood sugar and it's 204. Based on this scale here, then you would give yourself 2 or your patient 2 units of blood sugar or of insulin. Don't get hung up on memorizing this table because it's going to change. This is an example of a low sliding scale insulin, but there's low, there's medium, and there's a high scale as well. And it won't be up to you to memorize the table because that's always going to be provided within your medication reconciliation, your MAR. But just understand that that's how it would work. You check the blood sugar, and then whatever that number is will determine how many units of insulin you administer. And to be a good nurse, you're not going to go off your memory because stuff changes. You will always want to check just to make sure you're giving the right amount of insulin. But that's what the sliding scale insulin is kind of all about. So that concludes the the insulin component of this lecture. What we're going to talk about next are going to be the oral diabetic medications. I'm going to post online just another chart. You can certainly fill it out if it helps you, but again, comparing and contrasting the different types of insulin because sometimes that really trips people up. That's nothing you have to do if you don't want to, and you certainly don't have to turn it into me. In fact, I'd prefer you not to, because I may or may not have, I mean, I'd certainly look at it if you want me to, but you don't have to turn it into me. It'll just be there as another resource for you, so kind of keep your eye open for that. Now, the next part of the lecture is just going to get a little bit monotonous, I'm warning you now, but it's important to go through, and this is going to be the oral anti-diabetic drugs. These types of medications are going to be first line for your type 2 diabetic patients. When they're first diagnosed, they'll almost, well, depending on how severe the disease is, they'll start them on an oral agent. And they'll just start them on one to start off with. If one doesn't work for the patient, then they'll do two different agents, and you'll see some of them are used in combination with each other. If they select two types of oral agents, they need to find two that have different mechanisms of action. If those two agents together don't control the blood sugar, that's when they'll start introducing insulin to the type 2 diabetic patients. So just with that in the back of your mind as we move forward, that's where these kind of fit into the picture. The first type we're going to talk about is the biguanidine, and these are going to be your metformin drugs. And these are such amazing drugs. I just wish I could put a handful of them into each one of your guys' mailboxes, because they're just fabulous drugs. They're great for type 2 diabetic patients, and they're great for a couple of different reasons. When you look at their mechanism of action, first it decreases glucose production by the liver. By doing that, the liver is not going to be haphazardly releasing glucose at random times to spike your blood sugar up, so it keeps your liver in check. Also, while it's working on the liver, it helps decrease the production of bad cholesterol, of the LDL. So it'll actually lower LDL cholesterol, which is great for your diabetic patients, because the higher the cholesterol, the increased risk of developing those plaque formations that we talked about with complications. Also, it increases the peripheral glucose uptake of cells, so it makes those cells a little bit more receptive to taking in glucose. If that's not enough, it also decreases the intestinal absorption of glucose, so every time you eat your bag of Doritos, less carbohydrate gets absorbed into the system. And then it improves the insulin receptor sensitivity. So if a patient happens to be taking insulin as well, it makes those cells more receptive to the insulin. So, or even if it's just the patient's natural endogenous insulin, requires either less exogenous or synthetic insulin, and it makes the body more receptive to its own insulin too, which are both great things for your diabetic patients. As far as indications go, type 2 diabetes, but not type 1. This is not indicated for type 1 because you need to have a functioning pancreas in order for this drug to do its magic. Also, sometimes people take this to lose weight because it's decreasing the absorption of glucose, and then it just works to induce weight loss. And the other common indication you'll see this used for is polycystic ovarian syndrome. It's not unusual to see patients taking it for that as well. Now, although this is an amazing drug, there are a few contraindications with it. The first one's going to be renal insufficiency. Although this is a great drug for diabetic patients, it is very hard on the kidneys. So if a patient already has compromised kidney function, this might not be an appropriate drug. The next one is going to be if a patient has lactic acidosis, and we'll talk a little bit more about that in a few minutes, but if they're already in an acidic state, this drug will make it worse. And then the same thing with alcoholism tends to not play well with this medication. Not that they can't drink at all, but if they've been a chronic alcohol patient and they're coming in with decreased liver functioning and some other issues, it just doesn't work well with this type of medication. Some of your adverse effects. I've got this broken into common, serious, and then some of the helpful side effects that this has. Common is going to be abdominal bloating, nausea, feeling of fullness, and diarrhea. Now, some of the more serious ones are going to be renal failure and lactic acidosis. With this medication, when patients take it, sometimes they'll have a buildup of lactic acid in the system. And if you've ever worked out and you've felt sore the next day, you've probably been told that that's just because you have a buildup of lactic acidosis from your muscles, building and breaking down and then building back up. It releases it and it's okay. This is that type of condition times about 100. And with this type of condition, it no longer goes from being okay to more of a serious, sincere side effect that you have to be concerned about. So if a patient starts taking metformin and then they start complaining of severe muscle pain and weakness, they need to come to the hospital right away. They'll check some labs and they might have to stop this medication. Also, sometimes they'll just check electrolytes a couple weeks after starting the medication to help ensure that the drug's not starting to cause the lactic acidosis buildup. Some of the more helpful side effects though, weight loss, which is great for your type 2 diabetic patients because again, they tend to be overweight anyways. And then it also lowers the LDL levels, which again is beneficial for patients who have diabetes. Another hint, I'm just full of hints I guess today, but as you're looking at your cholesterol, your LDL is the type of cholesterol you want low. So I always think LDL low, the L to the L, and then your HDL level is the level you want high, the level of cholesterol you want high. So I just remember the H for the high level. And this lowers the bad cholesterol. Now, the only drug you need to know from this group is metformin. It's the only drug on the market because it's that good. I don't know if that's the true reason why it's the only drug on the market or not, but I thought that was a good catch line. With this medication's first line for newly diagnosed type 2 diabetic patients. So when somebody's newly diagnosed with this, with diabetes, they'll be started on metformin. As the disease progresses, or if metformin is not able to control the disease, then they'll add another agent that acts in a different way, and if that still doesn't work, then they might have to do insulin. It can also be used off-label for various things that we've kind of talked about, the polycystic ovarian syndrome, and then sometimes people use it for weight loss, sometimes it gets used for cholesterol. It's just a good medication. Again, it can be used in combination with other agents, or it can certainly be used as a standalone therapy too, especially with your pre-diabetic patients or patients who are newly diagnosed but don't have any chronic complications yet. This is sometimes a really good alternative, and although it has some significant side effects, a relatively safe medication. Now that I've said that, I do want to pull your attention to the fact that it's contraindicated in patients with renal insufficiency. Now this becomes a problem because a lot of your diabetic patients will come to you with some sort of compromised kidney function. If they have compromised kidney function, then this medication can't be used because it will just fry what little kidneys they have left. Also, because this is really hard on the kidneys, it needs to be used in caution with other medications which are harsh on the kidneys. And this includes NSAID therapy such as ibuprofen. So patients who are on metformin really should not take anti-inflammatory NSAIDs such as ibuprofen, Aleve, naproxen, Advil, all those medications because they're also hard on the kidneys. In addition, the other thing that sometimes gets these patients is if they go in for a CT scan for whatever reason, and they do it what they call a contrast CT scan, so they'll insert some dye into the veins to make whatever organ they're looking at light up, essentially. That dye they use is also incredibly nephrotoxic. It's very hard on the kidneys, so that in combination with metformin is also a really bad idea. For that reason, while patients are on this medication, they're going to be monitoring kidney function fairly closely. And the labs we watch with the kidneys are going to be the BUN, creatinine, and the GFR. Your BUN stands for a blood urea nitrate, and then your creatinine as well. Both your BUN and your creatinine are byproducts of muscle breakdown. So if your kidneys are working well and you take a blood sample, you're going to have low BUNs and low creatinines because your kidneys are excreting it. If you have a high BUN and a high creatinine, that indicates your kidneys are not excreting those muscle breakdown or byproducts. The last one there is your GFR, and that stands for glomerular filtration rate. And that is simply assessing how many mils per minute the kidneys are filtering of blood. So your kidneys, one of their many jobs is to filter blood and to filter byproducts out of your blood and waste metabolites and all that stuff out of your blood. The more frequently your blood circulates through your kidneys, the better it is at doing this. So if you have a high GFR, you have good functioning kidneys, you should have nice clean blood. If you have a low GFR, that indicates that your kidneys are not filtering as quick as they could be, and it's going to indicate that you have some sort of kidney insufficiency going on. Your normal labs for these, you can certainly look them up, but your BUN is typically less than 29, creatinine is typically less than 1.2, and then your GFR is greater than 60 mils per minute. Moving on to the next group of medications are going to be the sulfonylureas. Now this is the oldest oral anti-diabetic agent on the market, but it's not necessarily first choice. It'll typically be used in addition to metformin, but it's certainly one of those in addition to medications. The reason why it can be used with metformin is because it acts in a different mechanism of action. Metformin was working largely on the liver to help control the liver and prevent the liver from doing crazy things. These medications are actually going to work on the pancreas. And what they do is they bind to the beta receptors and they stimulate the release of insulin. Another helpful hint, if I tell you a medication stimulates or mimics insulin, stimulates the release of insulin, or mimics insulin, be thinking that it can cause hypoglycemia. If a medication is working on the liver, it most likely is not going to cause a hypoglycemia. Now that's your generic rule of thumb. It's not that it can't never ever cause it, it's just not likely to. So that's just something as you're going through and you're reading here. If it's working on the pancreas, be concerned about low blood sugars. If it's not working on the pancreas, don't be quite so concerned about it. Back to the sulfonylureas, in addition to stimulating the release of insulin, it also decreases the secretion of glucagon. Glucagon is like your body's natural sugar, so again, when your blood sugar falls too low, this gets secreted to help bring it back up. Indications for using this medication is going to be type 2 diabetic patients. Because you need a functioning pancreas, it is not going to help type 1 at all, so it's not going to ever be used for a type 1 diabetic patient. And it doesn't have really very many off-label uses like metformin does because it's just not as good of a drug. Some of the contraindications, because it can cause a low blood sugar, if you check the blood sugar and it's low, you're not going to give this medication. Even if it's ordered, you're not going to give it because it's going to cause that blood sugar to go lower. So it's contraindicated in patients with hypoglycemia. And then there's also a cross allergy with sulfa antibiotics. It's not that they won't order this medication if a patient reports an allergy to sulfa drugs, it's just that they're going to use it cautiously and know that there is that potential for if they're allergic to a sulfa antibiotic to also be allergic to these guys. And then again, type 1 diabetic patients, not that's going to hurt them, but certainly isn't going to help them. Some of your side effects, I've got this broken into common and severe, and you'll see hypoglycemia shows up on both sides of the screen. It's common, but that can also be quite severe as well. So that's why I did that, just to stress that importance there. Can cause hypoglycemia because it's stimulating the pancreas to produce insulin. Can also cause weight gain, so we'll encourage patients when they start on this medication to make sure they adjust their diet and their exercise to account for that anticipated weight gain as well. Remember, your type 2 diabetic patients tend to be overweight, so it's really important that they not gain any more weight because of their medications, if it's possible. And also some nausea and heartburn as well. You're going to be taking this with food, and taking it with food or giving it with food should help decrease the nausea and heartburn side effects associated with it. Some of the more severe adverse effects include hypoglycemia. If it's not caught early and not treated, that can result in death. And then this classification of drugs is also kind of hard on the liver, so you'll want to watch liver functioning. To assess liver functioning, typically we'll follow two labs, the AST and the ALT. And as a rule of thumb, both of those labs should be less than 50. We'll also encourage patients not to abuse alcohol. If they have a drink, make sure it's moderate, once in a while, not a daily thing, because alcohol can also induce hepatotoxicity. Another example would also be encouraging them to avoid Tylenol, because Tylenol can also induce that liver failure. So drug profile, I've got two here you need to know, and these drugs are going to start sounding a lot alike, so just bear with me. But you have glucotrol and Amaryl, or glipizide and glimepiride, and again, they sound alike, and they act alike, so you can group these two together as a sulfonylurea. They're both considered second-generation drugs. There are no first-generation drugs on the market that I'm aware of, so that's why we have second-generation ones. They're a little bit newer, and they're okay at what they do, I guess. They have a very rapid onset of action for an oral medication. It takes them about an hour, and then they have a short duration of action as well, about 6 to 8 hours. These will typically be a drug that people take twice a day, with breakfast and with supper or dinner. And if they're not going to eat, they should not take these medications. Because they stimulate the insulin release, we tell them to take them about 30 minutes prior to eating, so these medications have a chance to get into the system and start working before the carbohydrates introduced to the body. And if the patient doesn't eat, it will result in the hypoglycemia. And that is why if they're NPO, which means they're not eating for, say, surgery or a test or a disease state or whatever it might be, you're not going to give this medication because giving it's going to induce hypoglycemia, and then you're going to have to treat the patient for that reason. The next group of medications we have are the glinides here. These are another one which stimulate insulin secretion from the pancreas. The indications, they're very similar to the sulfonylureas. They're just not quite as effective. But your indications are going to be type 2 diabetes, and since they act in a different way from metformin, sometimes it'll also be used in combination with metformin. Now, you're not going to use these drugs in combination with the sulfonylurea because they act similarly. So if they act similarly, you want to avoid using them at the same time because it doesn't do the patient any good. Have to have two different mechanisms of actions. For contraindications with this, again, if they're hypoglycemic or if they have type 1 diabetes are going to be your main contraindications here. Your adverse effects, hypoglycemia and weight gain. Again, you'll want to make sure you're educating your patient to avoid gaining weight, especially since they're type 2 diabetic. So encourage exercise, diet, just discuss it so that they know and that they can take steps to help prevent it, because it's always easier to prevent than it is to reverse weight gain, in my opinion. As far as the drug profile, there's only one from the glinides you need to know, and that's prandial. Again, not to be combined with the sulfonylurea because it doesn't work that way. They work too similar, so they don't do any good. Now, one thing with this duration of action, it's a little bit shorter than the sulfonylureas were. For that reason, it's really not a big deal if a patient decides, I'm not going to eat lunch today. It's really not a big deal if they just don't take this medication and then they start taking it with their next meal. With the sulfonylureas, that becomes a little, you're not going to give it if they're not eating, but we really encourage them to eat because we don't like to not give the sulfonylurea because it screws it up. With the shorter duration of action, though, this one's not quite as big of a deal. Onset of action is still relatively quick, so we give it with meals. Give it right before meals, and then again, duration of action is about 4 to 6 hours here. And then this tired old medication that I thought I was going to have to not teach. In fact, I wasn't going to include it on the outline because we don't use it very frequently, and it's old and tired and probably ready for a retirement party. And then I was perusing an NCLEX review book that was just published a year ago, and I saw a question on this medication, so I thought, well, if the NCLEX is still testing you over it, I guess I'll include it in here. But keep in mind, this is not used frequently. This is really kind of the slow, retarded cousin of oral anti-diabetic drugs. Regardless of my personal opinion, though, how it works is it regulates the genes involved in glucose and lipid metabolism. And it does this by decreasing insulin resistance by enhancing the receptor sensitivity. Because it's working on the genes, it's not a very quick-acting drug. So it's got a very slow onset of action, which makes it not the most ideal drug. We just have better ones out there to control blood sugars. But because it's slow, it doesn't have the high risk of hypoglycemia, although it certainly can cause it. It's just not as likely. Indications, it's only used for type 2 diabetic patients. And then the reason why this isn't used so frequently is because of its contraindications and then the side effects, which we'll get to. This medication is contraindicated in patients with heart failure. And a lot of times patients who have been diagnosed with diabetes are at an increased risk for heart failure, so then giving them a medication which is going to hustle that along is not always a bright idea. It's also used cautiously in patients who have renal and hepatic disease, which your kidneys are also an organ that frequently gets damaged with this disease process. So again, although metformin does cause renal insufficiency, it's a much better drug. As a rule of thumb, though, we try to preserve what kidney and liver function these patients have left. Some of the side effects, again, it can cause hypoglycemia, it's just not as likely. It will cause weight gain, it will cause a peripheral edema, and it can also cause osteoporosis. And then, of course, heart failure is right up there as well. So not very desirable in that aspect. The only drug you need to know is Actos, and Actos is typically used in combination with another agent, such as metformin, which is really bad news for the kidneys. And it works to decrease insulin resistance, but it will worsen heart failure, so just make sure you're kind of aware of that connection with Actos. Okay, the next group of drugs, and bear with me, we're getting close to the end here, but the next group of oral agents is going to be the dipeptidyl peptidase IV or 4 inhibitors. And these are typically abbreviated DPPIV inhibitors. Mechanism of action for this drug is it delays the breakdown of incretin hormone. So this is going to work a little bit differently than what we've talked about so far, which makes these a good combination medication because you can combine them with metformin, with the sulfonylureas, even with good old Actos, and it will help increase the patient's glucose control. The incretins themselves, they're responsible for stimulating insulin secretion. They also reduce what we call a postprandial glucagon production. So once you eat, your liver produces this glucagon to help control stuff. This medication is going to help stop that production. It slows gastric emptying as well, which is going to reduce the amount of food you eat because you feel fuller quicker, which then helps reduce the amount of calories ingested as well. So they're a good drug. With reducing the appetite and the amount of food ate, it also reduces the fasting glucose level. And the only indication for this is typically type 2 diabetes. Although it might be used off-label for weight loss every once in a while, it's typically only used for the type 2 diabetic patients. Adverse effects of this group of medications, weird upper infection is one of them. I say it not that's a weird upper respiratory infection, it's just weird that these drugs cause it, and I honestly have no idea why. So if somebody wants to look into that and let me know, that'd be awesome. Just know that for some reason these drugs can increase your risk of coming down with an upper respiratory infection. And then hypoglycemia, especially if it's used with another agent such as a sulfonylurea that has hypoglycemia associated with it as well. Then the last side effect would be pancreatitis. And I haven't been making this a big deal as we go through the outline, but also knowing any drug which acts on the pancreas, so stimulating the release of insulin, does have the risk associated with pancreatitis. And there's also some new studies out there thinking that insulin or suggesting insulin can cause pancreatic cancer. Long-term insulin use can cause pancreatic cancer. It's not hardcore evidence, but just kind of know if it's working on the pancreas, there is a risk of pancreatitis associated with it. These drugs tend to be a little bit more likely to cause a pancreatitis. And patients who develop this side effect are going to complain of severe pain after eating. It doesn't matter what they eat. If it's a sip of water to a fatty meal, they're going to have severe pain. And then when they come in and you draw labs, they're going to have elevated lipase and amylase labs as well. So that's what pancreatitis, it's just inflammation of the pancreas. We typically put the patient NPO so we don't let them eat or drink anything. Give them pain medication, and it's normally something that kind of resolves itself after a few days of not eating, but it's very, very painful for patients to undergo. The two drugs you need to know here, we've got Januvia and we've got Byadea. Following your outline and not the PowerPoint here, Byadea is actually a subcutaneous injection, so this Byadea is not an oral agent. All the rest that we've talked about since covering insulin have been oral. This is a pin. It looks just like an insulin pin except for it's blue instead of orange. Administered subcutaneously, and your little trivia for the day is it was actually derived from the saliva of a Gila monster. So that's kind of funny. We've got a couple medications that come from really weird sources that I have no idea who thought that that would be a good thing to try, but they did and it worked, and here we are. The other medication within this category is Januvia. Januvia now is administered orally. This is not an injection, it's an oral medication. Where it comes from, I don't know, but it's working on the incretins again. They're both category B, so they can be taken fairly safely during pregnancy. And they can be taken without regards to food, which makes this a little bit easier. And it's typically just a once a day thing, so they'll take it every, typically it's in the evening, they'll take it every evening. The Byetta anyways is typically an evening medication. And then Januvia, I don't know that it matters if it's evening or morning. Normally when I give Januvia, it's in the morning, but I don't know if that's a really hardcore rule or not. Okay, so now we're talking about injectable but not insulin anti-diabetic drugs, just to confuse you a hair further. For the mechanism of action here, now we're talking about amylin, and these are going to be an agonist to amylin. What amylin is, if you've not heard of it before, it's a natural hormone and secreted by the pancreas in response to food. So when you eat, your pancreas does it does many things, but two things that we're concerned about. It secretes insulin and secretes amylin. By secreting amylin, it slows gastric emptying time. It also suppresses the glucagon secretion, the hepatic glucose production, and it increases satiety. By increasing satiety, that makes you stop eating, so it fulfills your appetite so you don't just keep eating and eating and eating. That's what it naturally does in the body, so now we're just going to give a medication to increase those actions. So it really slows down the gastric emptying time, which then makes you eat less because you feel fuller faster. Increases your satiety, so you feel full longer as well as faster, and then it's also telling the liver to not go crazy with its glucose as well. Indications. This can be used for type 1 or type 2 diabetic patients, which is pretty exciting. That can also be used for type 1 diabetic patients. Up until now, unless it was insulin, I said it didn't work for type 1 diabetes. This would be the one exception to the rule. And for type 1 diabetic patients, it's kind of exciting because this was the first drug approved for type 1 diabetes since insulin was approved in the early 20th century. And this is a relatively new, I'd say it's within the last 20 years, this medication came on the market, so kind of cool. Adverse effects, because it causes you to feel full, patients will complain of a full feeling or feeling bloated. Also a little bit of anorexia in the fact that they don't feel like eating. Not that it's an eating disorder, they just don't feel like eating as much, which isn't always a bad thing. And then some nausea and vomiting as well as they get too full. The drug you need to know here is Similac, and again, it's the first drug approved for type 1 diabetes. Now, keep in mind that this is a combination medication. This is not a standalone treatment. So type 1 diabetic patients will still be on insulin, but then some of them might also be on Similac as well to help control their blood sugar. But they'll never ever just be on Similac. It's got to be used with something for type 1 diabetic patients. It's an injection, and you've got the dosing up on the screen. For type 1, they need a little bit lower dose. Type 2 gets a little bit higher dose. Pregnancy category C, probably because a lot of research really hasn't been done on it in pregnant women. And that's probably okay because we have insulin that we know is a category A. So in gestational diabetes, insulin will still be the go-to medication for that. But this is an alternative for type 1 diabetic patients. Okay, so our very last topic in this outline is going to be hypoglycemia. And essentially what hypoglycemia is too much insulin in proportion to the available glucose in the blood. So all the glucose gets a parking spot, if you go back to that analogy, and you're left with nothing in the bloodstream. When you don't have glucose in the bloodstream, it causes problems. It's also technically a blood glucose of less than 70 milligrams per milliliter. And why this becomes a problem is your brain needs glucose floating in the stream in order to function. If you don't have glucose in the stream, you're going to start having clinical manifestations. It also stimulates the sympathetic nervous system to secrete. What it's trying to do is get the liver to let go of some glucose to bring the sugar back up. If your liver is not able to do that for whatever reason, your blood sugar is just going to keep falling and it's going to cause some pretty significant issues. Now, the reason why I highlight the fact that it's your sympathetic nervous system that's bringing about the liver, trying to stimulate the liver to let go of some glucose, is because a lot of our clinical manifestations come from the stimulation of the sympathetic nervous system, particularly the neurotransmitters epinephrine and norepinephrine. So if you think of stimulating the fight or flight, you get kind of shaky, perhaps a cold sweat, diaphoresis, some palpitations, heart palpitations, nervousness, anxiety. Those types are very much so a sympathetic nervous system issue. You can also add tachycardia onto there, and these patients also get very pale, cold, and sweaty. A cold, clammy sweat, I should say. The other thing we note with these patients, because the brain's not getting enough carbohydrates to function, our mental status changes. And this will go from kind of some slight lethargy and confusion to difficulty talking to difficult to wake up, and then they can fall into a coma, have a seizure, and that's what would make this condition lethal. So we do need to treat it when it occurs. And if a patient's taking insulin, sooner or later they're going to experience hypoglycemia. Even people who aren't taking insulin, it's not unusual for people to have a hypoglycemic event at some point in their life. So it's good to know how to treat it. And if it's minor, so if you can catch this in the early, the tachycardia, hunger feeling, kind of cold, clammy sweat, just not feeling quite right, the best thing to do is to get them a carbohydrate to replenish the carbohydrates in their bloodstream. And the go-to thing is orange juice. We'll give them a serving of orange juice and it brings their blood sugar right back up. When you take this course in this topic in a more in-depth course, they'll talk about the rule of 15. We get 15 grams of a carbohydrate, so one serving of orange juice, and then recheck the blood sugar in 15 minutes. If it's still low, they get another 15 grams of carbohydrate, so one more serving of orange juice, and then we recheck in 15 minutes. If it's still low at that second check, that's when we send them to the doctor to get evaluated. And then again, we call that the rule of 15. Now, diabetic patients are also going to have one more tool on them, because if this becomes serious or severe, they might not be able to drink that orange juice. So they'll carry what we have, like these little dissolving tablets of a concentrated glucose. And these can either be something that they drop into their buccal pocket in their cheek, or it might be a semi-solid gel form that they swallow. Both are absorbed really quickly, so it's just a quick burst of sugar to help bring their blood sugar back up. Reverse some of the symptoms, and then they need to go eat. They need to check their sugar and they need to go eat. If they happen to be in the hospital and this happens and we have IV access, we can push an amp of D50 of dextrose, and it'll be 50 milliliters, and 50% of those milliliters is solid dextrose and the other 50% is water. With this, it's essentially intravenous glucose, and this is a really difficult thing to push. So you push it slow, because if you try to slam it into the patient, you'll blow your vessel. And then you'll be trying to start a new IV and push this, and your patient will be crashing. It's just no good. So that's just my friendly advice. Make sure you push it slow, because if you push too fast, you're going to cause problems. And then the last thing we have is glucagon. Now this comes in a little subcutaneous injection. So when patients, and most of the time, especially type 1 diabetic patients, will just have it with them. It's kind of like an EpiPen for people who are allergic to bee stings. They just have it with them. And when they feel like their blood sugar is falling too low, they give themselves an injection, and then it brings their blood sugar back up. Now, as the glucagon brings their blood sugar back up, it may induce vomiting. So if you are the one administering this, say you walk in and your roommate's unconscious, you'll want to roll them on their side before you give this, because then as they come to, if they throw up, you want them on their side so they don't aspirate as well. Just be kind of thinking about that too. And that concludes our lecture over anti-diabetic agents.